Hello, I'm Sangjun YOO from Brahma Medical Center. My lecture topic is update on immunotherapy combined with chemotherapy for advanced metastatic prostate cancer. The lecture will cover immunotherapy for prostate cancer, chemotherapy and immunotherapy combination, and ongoing trials. The first part is immunotherapy for prostate cancer. The therapeutic effect of immunotherapy is affected by several factors, including immune microenvironment and tumor mutational burden. Among these, PD-L1 and TMB is currently regarded as independent predictive biomarkers that can each contribute to the identification of patients for immune checkpoint therapy. As shown in this figure, prostate cancer showed low PD-L1 positivity and low TMB compared to other cancers. In other words, prostate cancer is generally viewed as an immune cold tumor with limited activity of immune checkpoint blockade. Some prostate cancer patients with mismatch repair deficiency showed promising outcomes after pembrolizumab treatment. However, only 2 to 3% of patients with prostate cancer showed mismatch repair deficiency, and this low rate is considered to be a main limitation for treating prostate cancer using immunotherapy. Another studies reported similar results. Among the 1,033 patients, only 3.1% had high microsatellite instability or mismatch repair deficiency prostate cancer. Although these patients showed durable and acceptable outcomes after pembrolizumab treatment. Based on these studies, pembrolizumab is currently recommended in certain circumstances in patients with MSI high or dMMR metastatic CRPC, whose disease has progressed through at least one line of systemic therapy for metastatic CRPC. Because the prevalence of MMR deficiency in metastatic CRPC is estimated at 2 to 5%, immunotherapy is still limitedly used in prostate cancer. In this regard, many treatment strategies have been considered to enhance the effectiveness of immunotherapy for prostate cancer, and one of the most interesting fields is the combination of immunotherapy with chemotherapy. Chemotherapy could create a tumor milieu that augments the efficacy of immunotherapy. Treatment with docetaxel, a recommended first-line chemotherapy for metastatic CRPC, may enhance anti-tumor immune responses by increasing neoantigen presentation, stimulating pro-inflammatory cytokine secretion, and downregulating suppressive immune cell populations. Immunotherapy may augment this effect, providing a strong rationale for combining immune checkpoint blockade with docetaxel in patients with mCRPC. In this regard, at early 2020, clinical trial listed 55 ongoing clinical trials in which patients are receiving chemotherapy plus agent with known immunogenic cell death inducing potential in combination with one or more immune checkpoint inhibitors in patients with cancer. From now on, I'll introduce several ongoing clinical trials which use combination of chemotherapy and immunotherapy for advanced prostate cancer. This is a snapshot of ongoing interventional clinical trials actively recruiting patients with mCRPC. There are 150 ongoing clinical trials with 41 clinical trials with immune checkpoint inhibitors, including 6 chemotherapy and immunotherapy combination clinical trials for mCRPC. There are currently 6 ongoing clinical trials that recruit patients with mCRPC, which evaluate a checkpoint inhibitors efficacy in combination with chemotherapy. Among these, I will introduce phase 1b/2 Keynote 365, phase 3 Keynote 921, which evaluate the combination of PD-1 inhibitor pembrolizumab with docetaxel. In addition, I will also introduce Checkmate 9KD and 7DX, which evaluate the PD-1 inhibitor nivolumab in combination with docetaxel. Keynote 365 is a phase 1b/2 study to examine the safety and efficacy of pembrolizumab in combination with 4 different study medications in mCRPC. In Cohort B, the safety and efficacy of pembrolizumab in combination with docetaxel will be addressed. Previous data from Cohort B with a median 20 months of follow-up showed that pembrolizumab plus docetaxel and prednisone was well tolerated and had anti-tumor activity in patients with mCRPC previously treated with ABI or ENJA. New efficacy and safety data after an additional year of follow-up are presented at early 2021 in ASCO. Of the 104 treated patients, median age was 68 years. A quarter of patients had PD-L1 positive tumors and visceral disease, and half of patients had measurable disease. Median follow-up was 32 months. 101 patients discontinued treatment, primarily because of disease progression. Treatment-related adverse events occurred in 100 patients. The most frequent were diarrhea, fatigue, and alopecia. Grade 3 to 5 adverse events occurred in 46 patients. 5 patients died of adverse events. 2 patients were treatment-related pneumonitis. Efficacy outcomes are reported in this table. After another year of follow-up compared to 2020 data, pembrolizumab plus docetaxel and prednisone showed improved ORR of about 23% and PSA response rate of 34% compared to the prior dataset in patients with mCRPC previously treated with ABI or ENJA. This is Keynote 921, which is a multicenter randomized global parallel group double-blind phase 3 trial in patients with histologically or cytologically confirmed mCRPC who have not received chemotherapy for mCRPC and failed or become intolerant to one prior new hormone agent treatment. Treatment will be stratified before randomization by prior new hormonal agent treatment and metastasis. Keynote 921, which is ongoing or planned in 22 countries, will enroll approximately 1,000 patients, and estimated study completion date is early in 2023. Keynote 921 study will serve to clarify the role of pembrolizumab in combination with docetaxel and prednisone or pre-prednisolone in patients with mCRPC. Let's move on to Checkmate study. Checkmate 9KD is a phase 2 trial of nivolumab in combination with rucaparib, docetaxel, or enzalutamide for patients with mCRPC. Docetaxel is a standard of care chemotherapy for mCRPC that may potentiate anti-tumor immune responses, thus supporting its use in combination with nivolumab, which has shown limited anti-tumor activity in mCRPC as monotherapy. Arm B, docetaxel arm, enrolled patients with chemotherapy-naive mCRPC with ongoing androgen deprivation therapy and 2 or less prior novel anti-androgen therapies. Co-primary endpoints were objective response rate and prostate-specific antigen response rate. Of the 84 treated patients with a median age of 71 years, 27% have visceral disease and 54 had measurable disease. This table showed the efficacy outcomes, which appears to show comparable objective response rate regardless of prior novel androgen treatment, anti-androgen treatment. There was one complete objective response and 17 partial responses in 45 patients with measurable disease. Any rate treatment-related adverse events occurred in 95% of patients. The most frequent event was fatigue, followed by diarrhea and alopecia. Grade 3 to 4 treatment-related adverse events occurred in about half of patients, most commonly neutropenia. Adverse events led to discontinuation in about 30% of patients. The most common immune-related adverse events were GI-related toxicity or skin-related toxicity. There were 3 treatment-related deaths. Interim analysis of the 41 patients enrolled on the nivolumab plus docetaxel arm of the phase 2 CheckMate 9KD trial showed an objective response rate of about 40% and median radiographic progression-free survival of 8 months, providing the impetus for proceeding with the randomized phase 3 trial testing the combination in mCRPC. In this phase 3 trial, known as CheckMate 7DX, this study aimed to evaluate the combination of nivolumab plus docetaxel versus placebo plus docetaxel for men with mCRPC. Patients are randomized into nivolumab plus docetaxel or placebo plus docetaxel, followed by nivolumab or placebo alone. Enrollment is going with a target of about 1,000 randomized patients, so the aim to complete at July 2024 and the results are awaited. Here is the summary of this lecture. Prostate cancer is an immune cold tumor with a limited activity of immune checkpoint blockade. Treatment with docetaxel or recommended first-line chemotherapy for mCRPC may enhance anti-tumor immune responses and effect of immune checkpoint inhibitors. There are several ongoing clinical trials that recruit patients with mCRPC, which evaluate the checkpoint inhibitors' efficacy in combination with chemotherapy. Although the results of the phase 3 clinical trials are awaited, preliminary results showed at least 20 to 40% of objective response rate with acceptable tolerability. Thank you for your attention.